Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking, yeah, better thinking. Time to tune in. Let's go.
Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Paul Fitzgerald, who is the head of the School of Medicine and Psychology at the Australian National University. He is a qualified psychiatrist, has an MBBS degree, Masters of Psychological Medicine and Research PhD from Monash University. Paul has conducted an extensive range of more than 20 clinical trials, especially focused on the development of novel brain stimulation treatment options, including repetitive transcranial magnetic stimulation for patients with depression, schizophrenia, obsessive compulsive disorder, PTSD, autism, and Alzheimer's disease. He has had continual NHMRC grant support for over 20 years and over 10 million in research support in the last 5 years. Paul has published several books, over 500 journal articles, and been cited over 20,000 times. Paul has established multiple clinical rTMS services, founded several devices and clinical service companies, and the first rTMS training program in Australia. Paul led the national application to the Department of Health at the federal level, federal government level, and this resulted in Medicare funding $283 million in support for the first year of rTMS therapy for patients with depression in 2021. I deeply enjoyed this conversation with Paul, as TMS is something that I have had very little understanding around, very little knowledge of, and it was absolutely wonderful and a pleasure to have Paul on the show to discuss all things TMS. Enjoy. Paul, a big thank you for coming onto the show today.
You're most welcome.
Look, I'm really interested to find out more about this space around TMS, transcranial magnetic stimulation. It's something that I know very little about. I certainly know about it. I've had plenty of clients come to me and discuss it and how it's going and the like, but I don't know anything about the research, the mechanisms at play, or at least the theories behind it. So I thought, what an amazing opportunity, and thank you for coming on so we can discuss this further.
More than happy to talk about it.
Maybe before we begin, I can ask you how you got into this space. I know that you're a trained psychiatrist, but how did you find your way into this area?
It goes back a fair way. So I did my psychiatry training in the 1990s, and I was fortunate enough to have an opportunity to spend the last year of my training in Toronto at the what was called the Centre for Addiction and Mental Health at the University of Toronto. And I wasn't doing work with TMS. TMS was very much in its infancy during that time. But whilst I was in Toronto, the centre and my supervisor got a TMS machine. So I pretty much spent the last 4 or 5 months of that fellowship every Wednesday afternoon playing around, trying to work out how the machine worked. We weren't really trying to develop ways of using it in a treatment context. There were some interesting things that you can do with TMS in terms of investigating brain function. And my main area of interest at the time was thinking about what was going on in the brains of people with schizophrenia. And so that was the sort of focus of what we were trying to do. So I got exposed to it. I understood, what the sort of technology was. I came back to Melbourne, and where I was living after that and working in mental health service there, and wanted to continue with research. And I sort of had two choices. There was the other work that I'd done in Canada was with PET imaging. And when I got back to Melbourne, there was only one PET scanner, I think, in the whole country, which was in Victoria. But it was right on the other side of Melbourne. It was from memory, about $3,000 for a single PET scan. And it just seemed to be impossible to get a line of research up in that area, where it just seemed more feasible to try to do work with TMS. So managed to sort of cobble together a little bit of money over time, some borrowed equipment, set up a facility, and sort of went from there. Again, mainly focused on trying to investigate brain function, but it was right at the dying days of the Kennett government. And Jeff Kennett, sort of later became well known for his role in establishing Beyond Blue. I think had come back, had sort of become enthused by the need to develop treatments or to expand knowledge around depression. And we were fortunate enough to be able to put a proposal to the government relatively soon before they left office, and got a little bit of money for a TMS machine. And we're mainly wanting, again, to use that in people with schizophrenia, but felt obliged to actually do some research with depression, because that's what we had promised the government we would do. And so we started a small clinical trial, and lo and behold, people started to get better really quite dramatically. And I suppose it's, really from there that things kind of, developed over the years. That was really the starting point.
Mm-hmm. Can you talk me through a little bit about what TMS is? Because obviously there's a treatment avenue and there's an investigatory sort of avenue as well, and both avenues can be used with TMS. Talk me through what TMS is. How does it work? Because I genuinely have no idea. I don't even know what the machine looks like. So complete novice.
So there is a machine that sort of sits in the room next to the patient. I suppose it's a bit like a very large, oversized briefcase, sort of rectangular machine. It's connected to what's commonly called a coil, which a lot of patients describe as one of those old-fashioned head of a key. It's sort of this figure of 8 shape, and that sits on the person's head. It doesn't actually have to touch you, but usually just sits gently on the head. The machine effectively is gathering a lot of electricity and switching an electrical current through that coil on and off very quickly. The current is shielded from the body. There's no direct electrical stimulation, but the switching of that current on and off generates a strong magnetic field. The magnetic field is very focused and very local. It only goes into the brain a couple of centimeters. It stimulates an area of the brain of sort of 1 to 2 square centimeters, so a fairly local area. And the basic principle is when you switch an electrical current on and off, it generates this magnetic field. The magnetic field passes through us without any resistance. It's like why you can have an MRI scan to take pictures of your body. And when a magnetic field that is switched on and off very quickly is applied to something that conducts electricity, it will actually induce an electrical current. So we kind of start off with electrical current, reduce a magnetic field, and then the magnetic field goes back in the opposite direction and induces an electrical current. And our brains are full of things that conduct electricity, which are nerve cells. And so it's inducing an electrical current in nerve cells in the local area that's stimulated, and that's strong enough to actually make those nerve cells fire. So the easiest demonstration of that is if you put the coil over the area of the brain that controls, say, the muscles in your hand, and you turn it up to a high enough level, it will make the nerve cells underneath the coil fire, which will send a signal down to cause a muscle twitch in the hand, for example, which is kind of very weird because this thing, you feel a tapping sensation on your head, you get a sensation because it also stimulates the nerves in your scalp, but you get this sort of involuntary twitch in the muscle of the area that you're stimulating. And that can be useful if, these machines were originally invented because neurologists wanted to be able to track, the signal, the nerve signal from the brain down to, the hand or the leg or wherever it might be. But that's not necessarily sort of how or why it's used in a treatment context. In a treatment context, we're applying lots and lots of those pulses. And somewhat simplistically, the brain works on a use it or lose it principle, that the more we stimulate particular pathways, the more they become strengthened. We can change their activity levels. And so we're targeting an area of the brain and an area of circuitry that we think is involved in depression. And we're stimulating with thousands of these pulses over time. And we're trying to change the sort of activity levels in those pathways to bring about, therapeutic benefit.
And it's on that concept of use it or lose it. So if the magnetic impulses, or I suppose the switching the on and off of the current, which creates the magnetic impulse, that localizes or is targeted at brain centers that are responsible for mood, I'm assuming, or maybe behavior activation, or other areas that are generally associated with a desire to say, if they are not being used very much by the person who's in a depressive state, will that have an effect to activate that whole system and see some positive change in general? Is that kind of right?
Yeah, that's a reasonable summary. So the most common target for TMS treatment is what we call the left prefrontal cortex, so the sort of frontal area of the brain on the left. That was identified and originally targeted because early brain scanning studies tended to show that area of the brain was underactive in people who were depressed. Now, and so that was combined with a type of TMS which seems to increase brain activity. So we've got an underactive area of the brain, a technique to increase brain activity. Let's put two and two together and see if that produces benefit. And fortunately, it did. I certainly don't think that is all of the mechanism of action, because when we make a big bunch of nerve cells in these frontal areas of the brain fire, that area of the brain is very strongly connected to most of the other areas of the brain that are involved in depression. And depression is not caused by not having enough activity in your left frontal lobe. It's a complex network of areas. It involves a complex network of areas of the brain, some of which are overactive, some of which are underactive. Some of the thinking and cognitive centers tend to be underactive. Some of the more emotional centers as part of those networks tend to be overactive. So my belief is that, as I said, when we stimulate this area, we stimulate the nerves that pass through to these networks. And if we can strengthen those connections, we restore a more normal balance of some of those connections. And so we think, at least in part, that we can kind of restore the capacity of these cognitive areas of the brain to perhaps control some other areas of the brain, a particular thing called the default mode network, which tends to be overactive in people with depression, tends to be associated with things like rumination, the recurrent sort of negative thoughts that people with depression can experience. And it can perhaps help these executive or control parts of the brain switch off the default mode network and allow sort of more normal or more balanced sort of cognitive function to occur.
And when the treatment is being applied, what is measured in terms of those, where the electrical impulses go, or it's more measured about which area is being targeted? How does that sort of work as the, I suppose, the technician providing the actual treatment?
So this has evolved quite substantially over time. So there's been a lot of research looking directly, using various forms of neuroimaging at the effects of TMS, but the targeting itself started off really quite simplistically. It's very easy to work out, if you're looking at someone's scalp and you want to know what is the bit of the brain underneath that you're wanting to target. It's not necessarily all that obvious exactly where you should put the coil. One thing you can do really concretely is you can work out where the motor or the muscle area of the brain is, because you'll get that muscle twitch if you've got the coil on that spot. And so the original idea was to localize that spot and then to measure a certain distance forward to try to get over the right area of the brain. Now, that was good enough. It was certainly good enough to do trials that showed that TMS worked. However, if you do that and you move the coil forward a sort of a fixed distance, it doesn't take head size into account. Some people have small heads, some people have big heads. And we learned over time that we needed the coil to be a little bit further forward and a little bit more lateral, a little bit more to the side than we were getting with that sort of method. And so we actually did some studies going back to the late 90s where we would do MRI brain scans on people and then use those to localize the position of the coil using some sophisticated technology. And we found that produced better clinical outcomes. A lot of the more recent work has been done using functional imaging. So what we do under these circumstances is somebody goes into a scanner, they just lie at rest in an MRI scanner, and the MRI scanner is tracking effectively the blood flow into areas of the brain. And that helps us to map sort of networks in the brain, because areas of the brain that are communicating with one another a lot the blood flow will tend to kind of go up and down in sync with one another. And so we can kind of map those networks and try to establish where in the frontal cortex we really want to target. And that's given us a better idea of where we should put the coil, although we don't necessarily need to do brain scans in everybody before treatment. We've got ways of sort of working out where the coil should sit. But then we're really reliant on patients' reports of how they feel. You know, the most important outcome of treatment is not what happens on a brain scan, is that, you know, it's whether somebody feels better or not.
And has it remained targeted at the left prefrontal cortex? That's been the area that's identified and remained as the target space ongoing, or has that also developed over time in terms of where?
So that's still the primary target. A lot of work that we did going back quite some time now, and in fact, you know, right back to the early 2000s, showed that there was an alternate, which was actually to stimulate on the other side of the brain with a different sort of TMS, a type of TMS which actually reduces local activity. We were doing some brain imaging studies, and we found that when patients were engaged in tasks, when they were actually doing something in the scanner, rather than they were just lying there at rest, the right side of the brain tended to be overactive. So we tested a type of TMS that would reduce brain activity. That worked just as well. So that gave us two options. The right-sided treatment tends to be a little bit better tolerated. You know, most patients tolerate TMS well, but there would be, you know, maybe 3-4% of patients who really struggle with left-sided treatment. So right-sided treatment became a good option for them. And then when we knew that both left and right worked, it was a pretty obvious question to say, well, what happens if we combine them? And we do a sort of a type of bilateral treatment. And so we showed that worked as well. What somewhat surprisingly we didn't find, though, was that we had very much thought that the bilateral treatment would be better. But we weren't able to show that. It seemed that it would work to a greater degree in some people, whereas unilateral might work better in others, but it really seems to be relatively equivalent. So we can either treat people on the left, we can treat them on the right, or we can treat them sort of bilaterally, but they all seem to be pretty much the same. The only other really common, well, somewhat common variation now is a thing called deep TMS. So deep TMS is still targeted on the left, but it involves the use of a coil, a sort of more complicated coil, really, that actually sits almost in a bucket that sits over the head. It's a bit like one of those machines you used to see in movies, you know, 1960s American movies, where women would sit in a hair salon with these great big hair dryer things over their heads. And it's got a sort of complex set of coil windings that are able to generate a magnetic field that goes somewhat deeper into the brain. And so that's all used as well. It goes deeper, but it also stimulates a broader area across the cortical surface. And we're not really sure yet whether its benefit is because it goes deeper or just because it's, you know, stimulating a larger area of the brain in general. So I'd say there's really sort of 4 different sort of targeting or localization methods that are used.
It's interesting that so many different areas of the brain can be targeted, and there's positive efficacy for all of those. That's fascinating to see how obviously different parts of the brain, and as you say, they're very complex in terms of how they are connected with every other part of the brain in different ways. But that whether it's the left or the right, or potentially the deep TMS, that there's efficacy for all methods?
Yeah, look, I think there have been some approaches that have been tested and that haven't worked, and there's probably at least one or two others that I haven't mentioned where there's suggestions in studies that they might be effective as well, but they just haven't been shown in enough clinical trials to be of benefit that people have adopted them in clinical practice. And I basically think it comes back to what we were saying earlier on, which is that this is a disorder that involves a sort of complex network of areas, and we're really just trying to find a way to get into that circuitry, where ideally we would know the best node in these networks to target, if there was one that was better than any others. But we certainly seem to be able to tap into a couple of these nodes that allow us to get benefit. And so what we do now is good, it's effective. We still are doing research to see if there are ways to improve efficacy, but it's certainly I suppose, good enough and valuable treatment in the way that we currently do it now.
Mm-hmm. And how was TMS used in schizophrenia? Was that as a treatment base as well, or it was more research base?
It was both. We started off using it to test what I would regard as types of sort of brain plasticity. You hear a lot about sort of neuroplasticity and brain plasticity, but there aren't really many concrete ways that we can evaluate what that really means from a physiological perspective. Because these bursts of TMS can change brain activity, it gives us a way to actually test that directly in individuals by applying a period of TMS and then measuring something before and afterwards to see whether you get that same sort of neuroplastic response. And so, for example, if we're focusing on that muscle area of the brain that I talked about earlier on, we can apply some pulses to that area. We can measure the strength of the muscle twitch that we produce. We can then stimulate that with some TMS that's designed to try to make that area of the brain more or less excitable. And then we can measure again to see whether that's had the effects that it should have. And so that's kind of where we started. But we then did move on to trying to test ways of using TMS to treat various symptoms. We can't treat schizophrenia as a whole. It, again, is a complex disorder. But there are a couple of individual subtypes of symptoms that seem to be able to be potentially successfully treated in some patients. And the one that we focused on in particular was something that had been, there had already been some research when we started that was happening at Yale. A psychiatrist by the name of Ralph Hoffman had developed this approach. And it was really trying to target patients who had persistent auditory hallucinations, who continued to hear voices. There are quite a few people with schizophrenia, when they take the various medications that are required for that condition, who just continue to have these that are often very distressing and troubling hallucinations, even despite medication therapy. And Ralph Hoffman had come up with the idea that there was a continued overactivity of the sort of auditory memory or auditory processing areas of the brain. The thing that I really liked about this story was this wasn't I suppose the main accepted theory of hallucinations. If you would go to a conference of schizophrenia researchers, there was a very trendy, popular theory that was quite different to this that most people believed in. But he had this very strong belief that the one area of the brain that was involved, and if you could treat that, he could get therapeutic benefit. And he did an elegant number of studies at that in the sort of late 90s, early 2000s, and showed you could get therapeutic benefit. And so we became quite enthused by this and ran some of these studies as well, and also used TMS in clinical practice and showed certainly that you could get some really meaningful clinical benefits. It didn't work for lots of patients, but the patients in whom it worked seemed to get really could get really quite dramatic benefits, which was certainly something that can be very helpful for some patients.
What was the other popular theory at that time about where auditory hallucinations come from?
Yeah, look, it's still one of the leading theories. So the idea was that you're misinterpreting inner speech. So inner speech is the constant narrative that we might have in our own brains as we're sort of talking to ourselves as we go through the day, when we're not necessarily talking to somebody else in the world. And that inner speech is generated in areas of the brain more towards the front. In fact, potentially in areas of the brain associated with generating external speech. When I'm talking to you, I'm particularly activating an area in the frontal lobe known as Broca's area in the inferior frontal gyrus. And that when our brains are functioning normally, there's a signal that kind of goes back to the hearing or the hearing processing areas of our brain to tell us that that's me. I'm generating this inner speech, and that if that feedback loop is broken, we then start to experience that inner speech as an external voice. We're not recognize that it's our own speech. Now, that model kind of makes sense in some contexts. There are some people who experience auditory hallucinations who do genuinely experience a kind of a continued sort of commentary, something that you imagine could fit within this model. There's a constant, commentary during their day about what's going on. But there are lots of other patients with who experience hallucinations where that model just doesn't seem to work, where they hear multiple voices, they hear people talking to one another, they might hear crowds of people. And that, to Ralph, as I understood his thinking, and certainly to the way I see it, wasn't necessarily consistent with this sort of inner speech model, and was more consistent potentially with a lack of suppression of auditory memories, that there may be lots of auditory memories that are sort of bubbling to the surface and coming out because we lack activity of the circuits that are meant to suppress those auditory memories. And so the aim of the TMS was to try to inhibit or suppress that activity. And certainly that there is a sort of some validity in that, because it can work in some people.
And is the inner speech for those experiencing auditory hallucinations, is that often a different voice than their own? Or is it their own voice, but they are misunderstanding it as being not generated by themselves, so to speak?
Yeah, it's not experienced as their own voice. Patients with hallucinations can clearly distinguish between, this is me, and an hallucination by definition is experienced as being of somebody else. But the theory goes that because you lack this feedback, that's the reason why you don't recognize it as your own voice.
Mm-hmm. Mm-hmm.
So then you attribute it to somebody else, because where else would it come from? If it's not me, it must be somebody else.
Mm. I always understood as being a different voice to one's own, but also, at least through my clinical experience, it's predominantly been of the same gender as the person. I haven't seen as much where someone says the voice is a female voice if they're a male, and vice versa. In some sense, I feel that sometimes it might be easier to distinguish between the two if it's completely different gender, because there's an immediate recognition of it being different. But obviously it can be both. But is there a primary? Is the primary primary data that it's of the same gender?
I don't know that. My clinical experience would be similar to yours, but as I think it does come down to this issue of the heterogeneity of what people do experience with hallucinations. That there's a subgroup where it is one relatively single voice, and my guess, my anecdotal experience would be that would be more commonly of the same gender. But in individuals who are hearing multiple voices, there is a lot more variability. And some people will hear people talking to one another, and that could be of mixed genders, et cetera, and often and as I said, sometimes it might, some patients can describe a sort of a crowd of multiple people talking at once. And I don't think there's ever, I'm sure there is some phenomenological analysis of those characteristics, but I'm not aware too much of the details of that literature.
And so is TMS predominantly focused in those two areas, or is it quite a lot broader now? There's a lot more research occurring because it's starting to gain some more traction. Is it depression and schizophrenia predominantly, or we're seeing a wider sort of usage now?
So depression is by far and away the main indication, although it's used relatively occasionally for schizophrenia. It hasn't been clinically approved for that use in most places, just because of the nature of the clinical studies that have been done. The second application that was approved by the FDA in the US, which tends to be the sort of, the pathway through which most treatments become accepted, was actually for obsessive compulsive disorder. So that was the sort of second condition. And then most recently, there was a specific type of TMS approved for helping patients who were trying to stop smoking, on the background of a series of different studies exploring uses in addiction. So, and there are studies in the literature exploring the use of TMS in pretty much anything that affects the brain. People have tried it for just about any mental health or neurological condition, and there's varying data on different conditions. They're just the ones where there's been the sorts of studies conducted that have been able to satisfy regulatory authorities, which tend to be multi-site trials, often done by industry, because they have certain audit capacity and data quality related capacity that's able to convince people like the FDA that something should be approved.
And if we just focus back onto depression, what does the treatment look like in terms of frequency and duration and the like, and maybe you can then lead into what sort of benefits are people likely to get, and obviously we'll then maybe look at what are the sort of therapeutic gains over time that people at least statistically can expect.
Yeah. So a standard course of treatment, let me start again. The biggest problem with TMS, I think, we'll talk about the efficacy and safety and tolerability, where the story's all good in a way. The biggest problem with TMS is just inconvenient. You have to come into a clinic, usually Monday to Friday, for somewhere between 4 and 6 weeks. So 20 to 30 treatments is kind of a standard treatment. Over time, how long you need to be in a clinic each day has come down, as we've got methods that produce brain changes much more efficiently. So you don't need to be there very long, sort of 15 minutes is usually sufficient, but you need to do that on a regular basis over that sort of 4 to 6 weeks. If you miss a day here or there, it doesn't seem to matter, but you really want to have the treatment not spread out too much longer than that. When somebody has
Monday to Friday, we're talking about daily doses. 15 is
that's right.
But anywhere between 20 and 40 treatments. So
20 to 30 is usually 20 to 30 course. Although after 30, sometimes somebody might be having treatment Monday to Friday. We would often not stop suddenly, and go from 5 treatments a week to nothing. If somebody's done really well, we will often then wean them down. So we might have 3 treatments in the next week, and then 2, and then 1, and reduce it in that sort of way.
Sure.
The treatment itself, the person sits in a reclining chair, this coil sits on their head. They will feel a sensation, not because they feel anything in their brain, but because it stimulates the nerves and muscles in the scalp, sometimes around the forehead or even the upper eyelid. Most people tolerate that really well, but it can be uncomfortable, and occasionally it will be painful, this sort of strong sort of pulsing sensation. The machine's on for a couple of seconds and then there's a break. And so the sensations, can be strong and then it goes away. In most patients, we start with the intensity quite low to get people used to it and just gradually build up. And if we do that, the vast majority of people can tolerate a course of treatment. Occasionally, we might need to move, the coil slightly to get, if it just happens to be right on a sort of a sensitive spot. But the dropout rates are usually very, very, very low because of that discomfort. And there are certainly some people who this sort of pulsing sensation can give them a bit of a sort of a dull tension headache afterwards, especially in the first week or so, and they might need to take Panadol or ibuprofen after treatment. But again, that's fortunately rare. If it's going to work, most people don't experience anything straight away. It takes usually a week and a half, maybe 2 weeks before they're really starting to notice something, and then it will just gradually improve across the course of the treatment. Having said that, there's some people who get better quicker, some people in whom it's slower, but that's sort of the average, I suppose. And in terms of overall efficacy, in terms of what we really expect, is that we would expect that around half the patients we treat are going to get a really good response. Maybe another 15-20% of patients will get some benefit without it necessarily being life-changing, and there'll be about a third of patients in whom it doesn't really work for. And it's probably worth just talking a little bit about the patients who are having this treatment. This is tending to be offered to patients who've tried other things first. So the standard approval in Australia for TMS is that it gets used in patients who've tried at least 2 antidepressant medications of different sorts and or some form of psychological treatment. In reality, that's a good patient group to treat, but we will often see patients who've had 5, 6, sometimes 10 or even more medications. And it tends to work across that spectrum. But like anything, the earlier, the better. If somebody's having treatment who's only had 2 medications, they're probably a little bit more likely to get better than in somebody who's tried 10. But we still will use the treatment in people who've tried 10 because we do get some really great success in that group, although probably better off early on. And as I said, we're likely to be looking at sort of about a 45, 50, 55% response rate in that group. To compare that to medication, if you were to take a third, say you've had 2 medications, you haven't got better. If you're going to have TMS, you're going to have maybe around a 50% chance of getting better. If you have a third medication, the data suggests that at best, you're probably looking at about 15% of patients who are going to get better with that third medication. Once you've had a couple of medications, the likelihood that medication works drops away pretty quickly. So, certainly comparatively, it's a better option under those circumstances.
It's always so tricky because the mechanism that we're hoping is the one that leads to positive therapeutic gain is so hard to put a finger on. We theorize, we try and understand it, and everything still has the same approach, which is early intervention is best. Similarly, when I think about it, hopelessness probably hasn't become as entrenched, and the placebo effect is a bit stronger. And I know that we do this against control, so it makes sense. But it's so difficult to understand, like why is. I probably imagine that a similar thing would occur where medication is probably most powerful on its first round, second round, third round versus the fourth, fifth, or sixth. And maybe that says something about how the condition is at the time, and obviously it kind of is similar for it sounds like TMS. The earlier we can get in, the better it will be. But at the moment, it has to be, there's a criteria that has to be, in Australia at least, 2 medications that have been used prior to going for the TMS option. And what was the other category you said?
Well, I was just saying, if somebody has had a much longer period of illness, many medications, we certainly wouldn't say don't try TMS. And in fact, when I think back over the years, it's often in the patients who've been unwell for very long periods of time where you get the most noticeable and dramatic, impacts. I've had patients who've been persistently depressed for over a decade, and they have treatment, and suddenly their depression lifts, and it's just it's a remarkably satisfying thing to see. I remember. And this sounds very, very strange, and this is not obviously the standard, but I had one woman tell me at the end of her course of treatment, she says, I feel like I'm back to normal, but I never really knew what normal was. I've only ever felt this good on my second honeymoon. And that raised a whole lot of questions about her not feeling all that good on her first honeymoon, but she was basically, trying to tell a story about, that she'd had depression most of her life, really, and only, relatively limited periods where she'd been able to feel good, and TMS lifted her out of that, and she was able to have sustained benefit. The biggest challenge with TMS, from a practical perspective, as I said, it's inconvenient to have a course of treatment. It is like all treatments that we have; it's not curative. And I think it's important to say that. And so the challenge really then is, okay, if TMS works well, what do we do after that? How do we make sure people stay well for as long as they possibly can? And I fundamentally believe that, depression is not just a physical illness. It's a complex interaction of our social circumstances, our psychological makeup, the experiences that we've had during our lives. And so when someone gets better with TMS, we can use TMS on a less regular basis to help keep them well. If you have one treatment a week or one treatment a fortnight, that can really help. But it also opens the door for people to do other things that can make a meaningful difference in their lives. People, when they're depressed, often are stuck psychologically. They can't get out of those depressive, the depressive thinking. But they're also stuck in other ways. It's very difficult when you're in substantial depression to make the changes in your life that you might need to be in a healthier relationship with the people around you, to get out of a dysfunctional relationship, to get into a better job, whatever that might be, even to establish healthy living patterns. We know that mindfulness, practicing regular mindfulness is good for you, but when you're depressed, sitting down and trying to engage in meditation is extraordinarily difficult. It's a lot easier to do once you're better, and once you're well, we know that doing regular mindfulness and regular exercise are things that are going to help keep you well longer term. So, whereas TMS can, for some people, have really profound effects, and it can contribute to them staying well. It should. I would never say it's the be all and the end all. It's not the only part of long-term wellness. Long-term wellness is using an opportunity that people might get with TMS to try to then, put changes in place that can be going to help someone's well-being in the longer term.
I think it's important because there's, as a consumer of any health product, most people will naturally just move to that model of it's supposed to cure, it's supposed to fix, it's supposed to, it becomes that symptom removal or symptom reduction rather than an aid, and in there becomes part of the problem where, I've seen way too many times, whether it's even in my practice or for example, with introduction of medication, someone will say it worked, and then the next time they say it didn't work, and I know even in my clinical practice, the moment that a client says it worked, I cringe, at least internally, because I know that that's not what we're trying to do. We're trying to improve function, not symptom reduction, because, there is no medication that says, here's an antidepressant that will target that thought around loneliness, or that you are, not good enough and you're hopeless. There's no medication that does that. And similarly, I don't imagine that TMS claims to do anything of a similar nature. We're trying to do some sort of functional improvement rather than being targeted at specifically being able to achieve anything in particular, because it cannot claim that. It's just impossible to have any chemical that targets a specific thoughts, or a specific feeling ongoing. It might temporarily, but like everything, it's going to have either a tolerance that will build up, or it just can't be applied over and over and over again. You mentioned that TMS might need to be adjusted in terms of how it can be tolerated. Is that 15-minute mark the most regular? Does that sort of dial up for some patients? Does it dial down for others? Is it usually on a daily basis for that 6 to 4 weeks? How would that assessment sort of take place?
Yeah, so the way we do TMS has changed over time. So the forms of stimulation that target the left side of the brain have dramatically decreased in the amount of time it takes to actually administer the treatment. So when I first started, we had protocols that would last about 40 minutes. That came down gradually to 20 minutes. And then the dramatic change has been the introduction of a thing called theta burst stimulation, which is a more complex pattern of pulses that was originally shown in sort of neuroscience experiments to have more potent effects on nerve cells and their plasticity. And a standard theta burst stimulation treatment, the actual application of the pulses only takes 3 minutes. It takes you 15 minutes to come in and get things set up and so forth. But the treatment is very brief itself. Now, you're getting lots of pulses during that 3 minutes, and so it can be fairly intense. And as I said, there are some people who struggle to tolerate that. Worst case scenario is if somebody really struggles with left-sided treatment, is we'll occasionally, I'm talking maybe 1 or 2 people out of every 100, we'll switch them to right-sided treatment, because the way treatment's done on the right is pretty much tolerated by everybody. It's a bit slower. It takes 15 to 20 minutes to do, but they're just getting 1 pulse every second. It's like a clock ticking, and really, people will tolerate that pretty much universally. Whereas with the left-sided treatment, you're getting lots of pulses in a very short period of time, squashed together, and effectively what it's producing in your scalp is a bit of like a muscle cramp, because the muscle's not really getting a chance to relax for a couple of seconds. And in the scalp, that's usually okay. Probably the worst sensation that some people describe is if they're getting a stimulation in their forehead or in their upper eyelid. If you try to imagine getting a sort of a brief muscle cramp in your eyelid, it's a kind of strange and sometimes unpleasant sensation. But usually that's, as I said, dependent on exactly where the coil is, and some small movement around of the position can alleviate that. Sometimes we can drop the intensity of the pulses a little bit. And as I said, if we're really struggling, we can switch to the other side.
And in what sort of scenarios might there be longer exposure or shorter exposure? Is it predominantly based on how the client responds? And so it's client-led, saying, I'm experiencing this, I feel comfortable, we can maintain that, or, let's try for a longer exposure because I'm not getting what I'm sort of hoping for, or we change it because, maybe even be less, that might be more effective. How does a clinician make that assessment, or is it a fairly understood protocol that needs to be maintained at the present moment while more research is being done?
So there's 2 parts of that. I'll speak to the clinical, and I'll speak to some of the things that we're now doing with research. From a clinical perspective, we don't tend to change the dose that's given on a daily basis. So we wouldn't, double the number of pulses or anything like that, mainly because there is some complexity about the effects of these pulses if you continue the trains beyond a certain amount of time. There's some questions about whether or not the brain starts to adapt to them in different ways. So we might extend the duration of the treatment itself. Somebody might get to 30 treatments and turn around and say, hey, I'm doing well, but I still, I'm not quite there. Can I have another 5 treatments or something like that? So from a clinical perspective, we might change the dose in terms of the number of treatments, but not necessarily what we do on a daily basis. From more of a research perspective, we are certainly exploring whether we can use higher doses or different doses to get greater effects. And we've been doing research now for a number of years, investigating what we call accelerated TMS. So the idea here is can we give you a bigger dose, but for fewer days, to try to make it more convenient for you, so you don't have to come in as many times. And the holy grail here is also, can we get you better a lot quicker? So instead of it taking 2, 3, 4 weeks for TMS for work, can we get you better in, say, 1 week? Can we use, and could this then become a treatment for people who are extremely distressed, who need a very urgent treatment response, and will you be able to give a very high dose of treatment, say in a week, and get that response? And so we've done 3 or 4 different clinical trials exploring these sorts of accelerated protocols. Our research to date has basically shown that, yes, we can probably do things more efficiently, so get away with fewer days. It's still somewhat inconvenient on those days, and so it's not quite at the stage where we're integrating that into our clinical practice yet, because if you've got a busy clinic and you're treating lots of people across the day, and then you have somebody who's going to have one of these accelerated protocols that needs multiple treatment slots in that day, you're going to treat them several times, it becomes hard to schedule that. And so there's just some, logistical things we're working through. There has been a very promising finding come out of a place in the US, but I'm still a little bit guarded in our expectancy around this, which is a protocol that's what I would regard as extremely high dose. So they're effectively doing 3 times the dose continuously, and then repeating that 10 times in a day. So it's effectively 30 times what you would get in a single treatment in a day, and then doing that for 5 days in a row. So it's much, much higher in terms of the dose than anyone's done previously. The practical problems with that is that when they do it 10 times, so they'll do a 3-dose treatment, which takes, a little bit under 10 minutes. And then they repeat, the patient has a break for 50 minutes, and then it's repeated. So each cycle takes an hour. So the treatment in the day takes 10 hours. So there aren't many clinics that are even open for 10 hours, to do that, let alone, do you have to stop most of your other patients having treatment so you can do one patient with this approach? So there's some challenges with that. We are at the moment applying for a grant to try and see if we can drop that gap from 50 minutes down to 15 minutes, because then if you could do it in that way, you have a 2.5-hour treatment rather than a 10-hour treatment. That would be much more practically useful. The really exciting thing that has been shown in the preliminary studies anyway with that approach, and they are preliminary, very small numbers. It's only been demonstrated by the one group at Stanford yet. Nobody's replicated it yet. But what they found in 2 very early pilot studies is dramatic response rates. So very high rates of response, and patients getting better quickly. So, within that week, patients getting better. And that's faster than any other antidepressant treatment we know. Even, electroconvulsive therapy, which is reserved for, the most urgent and most critically unwell patients, takes longer than a week to get patients better when it works well. And so there's certainly something in this. I'm not sure that protocol that they've developed at Stanford yet is the right way to go. But if we can refine that, get it down to something that could be done in a couple of hours, and we could be getting patients better in a week, that would be, a really substantial breakthrough that could, make a difference, not just for patients that are in the community who can afford to wait, 3 or 4 weeks to get better, but even patients in urgent hospital settings where we need to get a response very quickly because they're very suicidal or they're so unwell that they've stopped eating and drinking. That would become a real bonus under those circumstances.
Paul, what's it like being a researcher in something like this where there's just so many unknowns? And I recognize in all research, I mean, always working with unknowns, and that's why exciting. But in something like this, it sounds like, I mean, the ethics would be very difficult to get around, and you could, I bet, speak much more widely on that than I can. But I imagine there's so much opportunity to look at, what would be the ideal framework if it did work, and then obviously taking a shot at it. It's kind of hard because as a starting point, it might sound scary that it's 3 times the regular dosage, and I don't know any of the medical sort of space. But one day that might be adopted and kind of not be something that anyone's concerned about. But I imagine that anytime you're going up, like in lots of things, exposure to anything, the upward trajectory is always a greater concern. We tend to be less concerned about going downward. But what's it like sort of thinking about and imagining how could this one day be applied in the sort of mainstream? Because there's opportunity to do this, trying to also consider how does it hit the ground, like going out and doing 15 minutes daily, for 6 weeks is a very difficult commitment for a lot of people. It's also very time, labor intensive. You've got to go out and train a whole lot of people, and it's not 15 minutes. It's actually by the time they get in and register and sort of set them all up and hook them up, and et cetera, et cetera. I don't know what the turnaround is, but, might be half an hour, might be 45 minutes, might be an hour for that treatment. But what's it like sort of thinking, what are the applications and how can we bring this into if something hits the ground a little bit more amenably for how a practice works or how a hospital works, etc.?
Yeah, look, it's a really good question. I'll just go back to one of the things you said right at the start of the question, which was around your dose increasing over time, and we've kind of been fortunate in some ways, although it's been frustrating in others, that the pathway of development of TMS has been a very long and somewhat incremental one. So if you look at the dose that was used back in the late 1990s, it was tiny compared to what we're using now, but that wasn't an overnight change. We gradually increased the number of pulses, the intensity, and gradually saw that things were safe over time. But there have been some very big steps along the way, and this one that I just was describing before is potentially one of those large steps. One of the things that the main part of your question, though, which is really, I think, about building in consideration about the clinical application to what we develop, is, I think, actually really important, and often, just generally speaking, something that kind of gets relatively ignored in normal research, where researchers are sitting in ivory towers doing their research studies, and it's sometimes very easy to forget about, well, what's this going to actually look like in real world practice? I was, I suppose, somewhat fortunate that, we were doing clinical trials, some of our clinical trials and some of our work in a clinical setting very early on. And by, the mid-2000s I was running a clinical program in a hospital in Melbourne. So as we were developing new ways of doing TMS, we would often try them out in the clinical setting fairly early on. And I think that shaped the way that I viewed this, which was always that if you're going to do something in a research setting or in a clinical trial, you need to know that this is going to be useful in the future. Otherwise, you're just wasting your time, but you're also, I think even more importantly, wasting the time of the patients who are giving up their time to participate in that research. And so you need to have at least thought ahead towards what some of those mechanisms might be. So at the moment, we're just about to start a new clinical trial here at ANU where we are testing a very different technological innovation. There's been a lot of technological innovation over the years about targeting, and we talked about that right at the start. But one thing that there's been very little technological innovation around is about individualizing the frequency of the pulses themselves. So there's a pattern to the pulses that we apply. They're applied at specific frequencies. And the language of the brain is in many ways what we call frequencies of oscillations. That the ways different areas of the brain talk to one another is by activity in those areas of the brain interacting at particular frequencies of the firing of nerve cells. So two parts of the brain where we know that they're talking to one another because the nerve cells are firing at the same frequency. And so the frequency of neural oscillations or neural firing is a really critical part of brain function. And we're administering TMS pulses at specific frequencies, but we've never really personalized that. We don't do an EEG and measure someone's brain activity, their brain, the way their nerve cells fire, and then use that to guide the way that we do TMS pulses. And we think that could be a really powerful way of improving response to treatment. So we're going to be testing that in a clinical trial. But that then is introducing another layer of complexity. And we have to be thinking, even before we do that, well, if this does work, how could that be used in clinical practice? How could we develop ways that a standard clinic could implement these methods? Because if it's too technically sophisticated, nobody's going to be able to do it, or there's going to be too much margin for error. So, so one of the people who works in my team over time has worked on methods to take the EEG signal and effectively just to clean it so it can be analyzed automatically. 5-10 years ago when we were doing EEG studies, we would have a PhD student doing an EEG study, and they would go and sit somebody in a chair and put these EEG caps on with these electrodes, record their brain activity. They would then have to go and spend several hours manually going through these EEG traces and removing things like if somebody blinked when the recording was happening, just the muscle activity from the blinking would cause a big artifact on the EEG trace. And they would manually go through and have to cut these eye blinks out. And they would literally spend hours for every subject. It was very tedious work. And so one of our team members has gone through and developed automatic algorithms that can just take the EEG data and clean it and process it and test it that's reliable. You don't lose anything meaningful from the signal, so that we're starting to think about, okay, if this approach works, could we develop a fully automated system that patient could come into the doctor's office, put a cap on, data would be recorded, it would be processed, and it would automatically generate a signal for the TMS machine to know, what frequency do we need to apply. If we can't do that, we might as well not do the clinical trial in the first place, because we're not going to be able to actually implement it if our new way of doing things turns out to be better. There's no point of being better if it can't work in the real world.
Yeah, it's such a balance and a tension between designing protocols and being informed by previous data and clinical knowledge with what could potentially land in the real world. And not only that, how does a community respond to what we think this new protocol might look like? And it's so fascinating. I always think about the iterative process of running a psychology practice. So many thousands of changes have gone into trying to set it up in its current form, as I'm sure your faculty has done for many, many decades, trying to just do the simplest of things. And it's hard to predict how something will be received, and that in and of itself is so psychologically driven, where we can dismiss something thinking that it won't be received, or go, oh, this would be fantastic, and put in so much research, only that there's some sort of challenge that happens on the ground that it's unforeseeable. But we're trying to kind of think so far ahead of going, how is this going to be received by, whether it's the clinic or the clients? How does empowering a client add value or subtract value when they can say as to potentially, how a dose might look? Does it remove the trust in the therapy, or does it actually improve the trust in the therapy and say it's more individualized to me? These are just completely unknown.
And the technology is really, in some ways, it's, I don't know if the right word's dangerous, but I have real concerns that it's possible to sell these sorts of technology, these sorts of treatments based on the technology, in ways that can be really misleading. There are already examples of clinics out there, promoting their forms of TMS as being better, or because they're high tech, because they are using imaging or they are using EEG in ways that are just not supported by real world evidence. They've got black boxes. They do EEGs and they say this is going to be personalized, or they're doing imaging. And this is in America, particularly. It's a very common thing in America, but it's happening here as well. Like there are a number of clinics that have popped up, and they're advertising the use of TMS for conditions where it's just not proven. Applications in children, applications in adults for conditions where there just isn't the clinical data, or where the science is used to, the technology is used to create an impression of science. You can do a brain scan and it's got some colorful blobs, and you can show it to a patient and say, look, here's this blob. This is why our treatment should work. And that can be really misleading. And I as someone who we've done clinical trials over the years that fail, that with things we do that don't work. I almost actually think that it's, that if you do research and things don't fail, there's something wrong, because not everything you try to test will work. There'll be, one treatment shouldn't work for everything, or it shouldn't work for everybody, and so, I think there's a real danger that we find the right balance between making sure that we genuinely test things in comprehensive research and evaluate it, but then also present it to people in a way that is honest and straightforward. But again, also, we shouldn't be trying to convince anybody that these things are miraculous cures, that this is everything. TMS, like any technology, if any technology that's good, is going to be part of the solution. It fits part of their journey. Recovery from depression is a journey. This might unstick you, but it's not going to solve the social problems. It's not going to solve your economic problems. It might help you get to a point where you can start working again, and that's wonderful. It might get you to a point where you can start to reevaluate what your relationships are, and so forth. But it's not everything. And technology is often presented, as this sort of miraculous solution. And I think that's really dangerous and something we have to guard against.
It's a problem in psychology, because any time there's any intervention, naturally the hope is of positive change. And psychology appreciates, as psychiatry does as well, is that hope needs to be moderated. Otherwise it can be problematic as well. If someone is high with hope, there's going to be a high opportunity for disappointment. Similarly, you don't want to have no hope, because then you won't try it. I mean, that in essence is what learned hopelessness can look like by Seligman, that we've all understood and learnt. It's that balance, but as you say, there aren't always the same insights by all the organisations that they can sell it in a more curative way. And I suppose that's why AHPRA is around, and regulation and the like. But it's hard, because the choice of language can be very grey, and people are desperate for for some sort of improvement for their loved ones, for themselves. And anytime intervention comes in, it's very, very, very much something that hope, builds around. Where would you, where would you say is a good place to start for people who, are listening to this and thinking about TMS as potentially being an option for them or a loved one? Where can they find out more? What are reputable places to consider, researching, going to, speaking to clinicians about that you know of?
So there is good information out there. The Royal Australian New Zealand College of Psychiatrists has a variety of information sources that are accessible through their website. There is a thing called the Clinical TMS Society, which is a predominantly American, but is an international society that produces some very good information for patients. That's the Clinical TMS Society, CTMSS. And there are lots of other sources. I've got some general links and things on my website, which is paulfitzgerald.com. People are welcome to come and have a look at the TMS information there. It can be challenging in talking to clinicians about TMS because even though it's been around for quite a long time, there's still a lot of ignorance around about TMS, and so often it requires patients to do their own do their own research. The clinical service that I'm associated with, which is the Monarch, M-O-N-A-R-C-H, Monarch Mental Health Group, we've got some hopefully very accurate and useful information on our website as well. And that's also can be found through TMS Clinics Australia. So if people follow any of those information sources, there's certainly plenty of good, reputable information out there. And as I said, there's been 50, 60, 70 different clinical trials evaluating the use of TMS. We know a lot. There are still gaps and we're still working on it, but there's certainly lots of good information out there for patients.
And what are some of the myths that you would like to dispel that you commonly hear, whether it's from clinicians, whether it's from clients? I mean, there are naturally, concerns that people bring to the table. What are some of the common myths that would be, useful for people to know or to have information around when considering, TMS?
Look, probably the biggest one is the biggest concern often patients have is understandable confusion about where TMS sits in terms of electroconvulsive therapy. Most people have heard of ECT and are quite anxious about ECT. ECT can be a very effective treatment, but there are lots of issues with having to have a general anaesthetic and some of the side effects. And so it's important for people to realise TMS is just a very, very different sort of treatment. There's no general anaesthetic. You're coming into a clinic, that could be just in the local shopping mall or your local practice very close to where you live. You're not asleep. You're awake throughout the procedure. There's no anaesthetic. And perhaps most importantly, there's no adverse effects of TMS on memory. People might have heard that ECT can produce memory impairment. In fact, TMS is quite the opposite. If anything, it tends to be pro or good for your sort of general brain function and memory. So much so now that we're actually doing clinical trials testing the use of TMS in people with memory problems like Alzheimer's disease. And we've got preliminary data to suggest that TMS can actually improve memory in people with Alzheimer's disease. So that's a really important aspect, and probably the biggest concern that patients can't have when they're coming to us.
It's a scary one for many because anytime you start looking at the brain, and obviously we've all seen the footage, the Hollywood footage for ICT in particular, ECT, my apologies, that were very frightening, and obviously early days in something like that, looked quite frightening. And so, it's something that naturally is of concern. I mean, there are people, there's lots of people out there that even are concerned about any type of exposure, whether it's chemicals, radio frequencies, mobile phones, there's all sorts of things that I think, healthy skepticism is important, and hence reaching out to you to try and understand, hey, what is TMS? I don't know anything about it, and trying to educate myself, find out a little bit more, and also hear from someone who does the research and has used it in practice versus someone, hearing it only from their clients. You don't get any of the other side to it, but it's lovely to talk to you today and find out so much more about it. What are your hopes for TMS for the future? Where do you see it going? What's the next step that you see that TMS will achieve? You're obviously in the space. There are breakthroughs that everyone's hoping for. Where do you see it sort of going in the next, say, 5 to 10 years?
So I think to my mind, there's probably 3 or maybe 4 different answers to that question, all of which I'm enthused about and excited about. We've touched on 1 or 2 of those already. One is about trying to come up with some of these more efficient and potentially, very quick to work forms of TMS. Related to that is by increasing the degree to which we personalize the treatment, we can get better clinical outcomes. Our ultimate goal there is that, using potentially imaging and EEG, we could come up with something that's just highly personalized and therefore very, very effective. And that's what we'll be testing in this new study starting in the next month or so here. The third thing that we need a much better evidence base around is the long term. We know we've got great long-term safety data. TMS has now been around for decades and decades, and so we're not concerned about that. But the use of TMS as a maintenance treatment, I've seen many patients, being able to stop their medication and just use TMS as the way to stay well for years. And I've seen patients using TMS for well over a decade. But the research data supporting that long-term use just isn't nearly good enough, and so it's not funded for that. So we need that data. And then probably the last area that I'm excited about, but which is a little bit tangential from TMS, is the use of similar but somewhat different technologies to try to develop what I would call home use treatments. Because as we've talked about a couple of times, the biggest problem with TMS, no matter how efficient we get it, is you have to come in and have it. And we've spent a lot of time and effort trying to develop clinical services that can be out in the suburbs and so forth, but there's never going to be a form of TMS that's as convenient as taking a tablet at home. And so the version of TMS, I suppose, that takes us much closer to that is, can we develop a device that somebody could use at home in the comfort of their own lounge room or bedroom that would produce similar benefits? And that would, one, be obviously much more efficient, cheaper, accessible to people in a variety of areas, including in rural and remote settings, and also potentially something that's much more convenient for the longer term. I don't think it's, people are trying to build very small TMS machines to give people to take home. I don't think that's a solution. I think, I think the solution is going to be similar but different technologies. There's a thing called transcranial direct current stimulation, which is a very small box, simple electrodes, seems to produce depression benefits, but I think the effects aren't nearly as strong as with TMS. We're really focusing our research on a third type of technology, a thing called transcranial alternating current stimulation, which again can be administered through a very small portable device, some simple electrodes on the head, and it uses what it sounds like. It's an alternating current. It goes back and forth like a TMS pulse does. And we think, but we don't know yet because we haven't proven it, that we can develop a form of that again is personalized, involves recording the brain function and using that to develop a personalized stimulation signal. And we're hopeful that that is a way to potentially develop something that people in the future could use at home as a much cheaper, much more convenient alternative. But that's something very much for the future, and we're relatively early on the journey of developing that form of technology.
It's exciting to hear about the research that's going on, and I'm always enthused and inspired. Not that I do any of that, but just inspired in life, that there are other options, that there are new possibilities coming up, and something like a home-based TMS machine, alongside many other approaches is exciting, because it just adds another leg to the table that makes it more stable, and if it works for some, then fantastic. I think that trying to make all these things commercially viable is also another great challenge, and like many things that are absolutely fantastic and founded in research, it's still very difficult to actually get them to land, and how that might look, even though everything, from a conversational point of view, my brain's firing like mad. In my mind, I'm like, yeah, and you could see your TMS clinician, and they could download, what you need onto your particular box. And so you could go out and have this tailored thing without needing to go get anything changed because technological advancement, et cetera, et cetera. But the complexities, it's easy to just say, you can get so excited, but, it's got to land, it's got to hit the ground, and have, all the approvals and the like, so we don't have, cowboys running the show, so to speak, and potentially do harm to others. So fantastic. Thank you so much, Paul, for your time. You've been incredibly generous, and I hope that you continue to get plenty of funding, that the school continues to push for these things, to understand how TMS can be valuable in whatever form it is, whether it's the repetitive, whether it's the deep, alternating, the direct current. It actually doesn't matter which one. The outcome's what everyone's looking for, and obviously safety as a important appreciation as well, so that it can have adoption rather than that fear response. And I imagine fear is a big one at the moment, that is always going to be challenging to overcome. But thank you so much. I appreciate your time and appreciate your work, and that's for you and your colleagues as well. I don't think researchers often get enough cred for the time and energy and effort they put in, because you guys, when it's coupled with practitioners, are the backbone, guiding what we should all be considering and thinking, and obviously practicing. So thank you, Paul.
Oh, look, you're most welcome. It's been a pleasure to talk about all these issues, and they're important. This is an extraordinarily common problem that people are faced with. Not just depression itself, but depression that is affecting people that's not getting better with other treatments. We just know there are just tens, if not hundreds of thousands of people struggling with these issues, and so it's important for us to be developing new options. But there's no point us developing options if people can't find out about them and learn about them, and it's only through mechanisms like this that people are going to learn about what's available and be able to make informed choices, which is ultimately what it's all about. We're not replacing things, we're trying to add to the options available to individuals, and so that they've got choice, they can understand and select what might work for them.
And it's a beautiful way to say it as well, Paul, because that's goes to the heart of how people think. They think we're trying to replace rather than, no, we're adding value. This is a value add in the world of psychology and support and health for people. So I think it's a nice place to end our conversation. And once again, thanks, Paul.
You're most welcome.
If you enjoyed this podcast, please support it by going to iTunes and putting a review, subscribe, share it via social media, and tell others about it. Start a conversation. It's listeners like you that make this able and possible, and why we bring in these guests to go out and share their knowledge and resources. And just lastly, If you are a psychologist and you want to go out and be part of a bigger team, develop your experience and get into some exciting work, come to strategicpsychology.com.au/careers and reach out. I'd love to hear from you.